thanks for making it the morning after the dinner. It's lovely to see so many people here. Just a few housekeeping things to start off with. My name is Fiona Nolan. I'm chairing for today, Professor of Mental Health Nursing at the University of Essex. We haven't got any fire alarms scheduled for today, so if it does go off, it's the real thing. And we've got an action-packed schedule for you today, so I hope you make it right to the end. And this morning is a momentous occasion, so you'll remember this when you retire. You'll think, what was I doing on that day? We have the first mental health nurse academic lectures scheduled for this morning, and I'm really looking forward to hearing them. We'll have time for questions at the end of the lectures, so in order to introduce them, I'm going to hand you over to the Chair of Mental Health Nurse Academics, Stephen MHNAUK.
Good morning, everybody. For those who don't know me, I'm Stephen MHNAUK. I'm Professor of Mental Health Nursing at the University of Manchester, and I'm also elected Chair of Mental Health Nurse Academics UK. And for those who don't know, Ben Hannigan is the elected Vice Chair of Mental Health Nurse Academics UK. Mental Health Nurse Academics UK was formed in 2003 and represents more than 60 UK higher education institutions involved in mental health nursing, education and research. We have a website now. We don't have any, it's had to be WordPress because we don't have any money. So if you want to know more about us, just Google MHNAUK, and I think we now end up as the first return at the top of the Google list. Mental Health Nurse Academics UK has got a long history of involvement in and support of what was the MPNR. I can't get used to the new name. I have to get used to the new name. It's now known as the International Mental Health Nursing Research Conference. Yes? Yes. Now, the conference organising committee wanted to recognise the long-standing association between Mental Health Nurse Academics UK and what was the MPNR and is now the International Mental Health Nursing Conference. And what better way to have a lecture in MHNAUK's name? And I'm stressing the a lecture, but you see, because we're contrary, we couldn't actually decide on a single lecture. So in this, it's an inaugural year, we've actually got 2 MHNA lectures for the MHNA lecture. So I'm delighted to firstly introduce a colleague of mine who's had a long-standing relationship with Mental Health Nurse Academics UK and actually a former chair. Dr. Michael Coffey, after which Professor Paul French is going to speak. So, handing over to you, Michael. Thank you.
Thank you, Stephen, and thank you to the committee for this opportunity to speak in this, the first of the Mental Health Nurse Academic UK lectures. I start off this morning with a contractual obligation to demonstrate the beauty of Swansea. You see? Please come visit. Julia Terry will put you up. I'm going to talk today about risk, about the language we use and possible consequences of the language we use around risk. I'm going to base my analysis on observations and research as a mental health nurse over the past 30 years or so. I'll show examples of discourse of risk from the studies that I've been involved in and what I think this means for people receiving care and for the profession itself. And I'll make a contrast between our professional focus as mental health nurses on the therapeutic relationship and evidence for what seems to me to be happening in risk assessment practices in mental health services today. Back in 1994, many of you will probably remember Tony Butterworth's review of mental health nursing. It argued for a focus on working in partnership with people in mental distress. And I think that we still have some way to go, actually, on that particular journey. And I think it's in risk assessment practice that we most clearly see the distance to travel and the lack of partnership. Therapeutic relationships are claimed to be fundamental to the work of our profession, and it seems to me inconsistent to withhold or deny involvement of people in discussions about their safety, especially given the limitations of those assessments and the possible consequences arising from them. My argument is that new forms of involvement and engagement in discussions about risk are required that more directly align with our claims to be a mental health nurse, and by doing so, we'll enable people who use services to build and sustain their agency. So in this lecture, I'm going to argue that how we talk about risk says something important about how the mental health system operates, how the work gets done, and how people delivering and receiving care make sense of themselves and the context of that care. For example, as I found previously in a study of forensic mental health nurses, when asked about what their primary role was, their response was always public protection. And that, to me, raises lots of questions about what it is to be a health and social care professional. And also it raises questions about how individuals using services might respond to people talking about them in that particular way. One example from that study is that people talk about themselves as embodying risk and about services themselves lacking trust. It's also led to the sociologist Nicholas Rose to claim that there's a focus on risk thinking in mental health services, such that the primary focus, task of mental health professionals has come to be less about therapy and treatment and more about the administrative management of potentially problematic persons. It was almost 20 years ago that we had that comment from Nicholas Rose, and I wonder how true it might still be today. In fact, organisations, I think, are now more than ever focused on reputational risks, and our processes have become purely administrative and not particularly helpful. So I'm starting from a position today in this talk about risk assessment that it has become little more than a fable. It's a fiction, I think, and it's unjust. It's unjust in the way that it's perpetrated because it works to deny people using services the possibility of contributing their knowledge to possible solutions. And in many instances, risk assessment has become an interactional accomplishment to deal with the uncertainty and reassure us all that something's been done to manage and what is largely uncontrollable. I think we could do better. It seems too now that our field of mental health nursing is constantly going over old ground in our attempts to understand and articulate what it is we do. It's unlikely, though, that many of us will have missed how our work has become more concerned about risk. When I walked through the doors of this place back in 1984, the word risk was rarely, if ever, mentioned, and seemed to focus mostly on the risks to staff of breaking many of the institutional rules. In institutions like this, there was a lot of doing to rather than working with people in mental distress. And I think this legacy is still partly responsible for problems in achieving meaningful involvement today. As students, we did learn a lot about relationships and listening and key mental health nursing skills, and I think today we can be fairly certain that therapeutic relationships remain fundamental, and I'll just move that on. Remain fundamental. They have a reasonably strong evidence base and are valued by workers and service users alike, although they remain, and they do remain a necessary, if not sufficient, condition for achieving change in people in distress. In our COCAP studies, we found significant associations between scores for relationships and high scores for recovery among services. So there may be an important function of these relationships that we're starting to see. And in our more recent study, we saw that in inpatient services, we saw that workers rate these therapeutic relationships higher than the service users do. We, of course, do need to keep people safe. We need to keep people safe within the bounds of our knowledge, and we must respect individual rights under law. So my argument, and it may be critical of risk assessment practices, is not that we need to stop doing risk assessments, but we need to think about how we're doing it. And we should not be making judgments based on fallacious assessments that limit involvement of people who are most affected. Risk assessments have come to foreground worker and system priorities, I think, while accepting weak evidence for their efficacy excluding or sidelining knowledge from the person and the families, with little transparency or scrutiny of the conduct of the actual assessments. The way they're conducted appears to me at least to be contrary to the claims that we make on behalf of an honest and respectful therapeutic relationship with individuals. Now, when I walked through the door of that place back in 1984, I had a sense of stepping into a world that hadn't much changed for about 50 years or so. But soon things did start to change. The 1990s brought with it a series of concerns about behaviours arising from people, behaviours of people with mental distress. And these were kind of crystallised, I think, in the UK with the killing of Jonathan Zito by Crystal Clearness, and by the events that were nationally broadcast on TV of Ben Silcock climbing into the lion's den at London Zoo. Risk had very much become part of the political agenda, and the responsibility was located with the mental health professions to deal with this risk. And we are appropriately worried about risk because, of course, harm does occur, and promoting safety is essential. In the UK every year, there are about, on average, there are about 5,500 suicides. 30% of those people are known to mental health services. And there have been increases recently among men, which seems to be associated with economic austerity, and recent concerns about risks of suicides, for instance, among university students, which many of us will be highly aware of, and benefit claimants, people who are using mental health services frequently. So we know that there are other types of risks, and they're kind of the less obvious risks, and they don't tend to get measured so much. Things like loneliness, neglect, and wider vulnerabilities are rarely estimated and get less attention. Risk and working with people to manage their safety is fairly integral now to care coordination approaches. And I think also, even if it weren't, I think we probably agree it's a moral and professional obligation that we intervene to help people and prevent them taking their lives. The other issue that, of course, has happened with risk assessment is that it's led to concerns about blame, so where it might lie. And because when we tally up the probabilities of risk and untoward events, we are also perhaps inadvertently maybe identifying who might be blamed for not spotting and managing the events that later unfold. And this has an immediate effect, I think, on the work that gets done, and perhaps more potently on what gets counted, so that the wider impacts are felt in the system of care. To me, it seems that the risk assessment is a wholly expected response to trying to figure out what is going on and to do something about it. An expected response for sure, but how risk assessments get done is largely unknown, and the services are becoming much more defensive. This has led, for instance, to the observation by Paul Godin, for instance, that the service has become more interested in ticking the boxes on the form, both metaphorically and literally. Rose has noted that this form of risk thinking brings the future into the present to make it calculable, so that risk determinations become the means by which professions think, act, and justify their actions. And this is worrying because there are potential serious implications arising from risk judgments. This can lead to a tension, I think, between practices that promote independence and those that shield workers. Even where workers are truly focused on the person in the risk assessment, there remains significant anxieties that they may be held accountable for events that are largely unpredictable. And we have a care coordinator here from our COCAP study indicating that some of the anxieties around taking positive risks and the lack of support that might exist within services. It seems that in the midst of this emphasis and the obligation to measure and predict, we may also be guilty of losing sight of the effect that changing discourses are having on our practice and the identity of mental health nursing itself. If we see everybody as a potential risk object, that is, everybody experiencing mental distress and embodying risk, then this changes how we understand people and orient towards them as human beings. In focusing too intently on the possibility of risk, we may be in danger of forgetting too of what it is to be human and make mistakes and to learn from those mistakes. It has also led to a focus on preventing and controlling rather than engaging with people. And this quote here from Rufus May from his blog from earlier this year gives an indication of some of the problems that might arise. I think more worrying still is this discourse on risk, harm and blame is also having an effect on the people our profession are meant to be helping. Language seems to be as important. Words do things. They can be extremely powerful, they can be helpful, and they can also be destructive. Words can help us do different types of things, and you might remember, if you think about words, if you're in any doubt about words and their strength, you might remember the persuasive effect of these sets of words. The £350 million a week for the NHS was persuasive, it seems, but it also turned out to be illusory, and their talk about judging risk may have a similar fate. The language of risk, as we know, is negative. It references difficult and distressing events and possible outcomes. So how we talk about risk implicates how we understand ourselves and how we orient towards each other. We may end up in situations in which risk starts to trump rights, as indicated by the first of these care coordinators from our COCAP study, or where the availability of choice is removed as implied in the second quote. The implication here, I think, is that individual identity is fixed and immutable. Once we've labelled something, it remains forever labelled. If we have a mental health problem, we're always considered to have a mental health problem. If we once stole a bottle of milk, we're always considered to be a thief. If we were ever violent or physically, in a physical fight, we would always be considered to be violent. If we were ever irrational, we would always be considered to be irrational. How we do risk and how we talk about it is relevant to how we understand people. Identity, or how we're known to ourselves and others, is a critical element of everyday impression management. We're all engaged in identity work much of the time. And how we come to know what it is we are, for the most part, created in interaction with others. We are held in high esteem or dismissed, and what we tell ourselves about ourselves helps formulate who it is we think we are. And we get multiple cues from that in our environment, so that Sue Westroff, for instance, noted that in people with enduring mental distress have come to know themselves as embodying diagnostic labels, and we seem to be in danger of adding the burden of various risk labels. I think at some level, many mental health professionals actually already know this. We have an intuitive grasp, I think, of the unreliability of many risk assessments, and perhaps too a fear of the effect of the language we use in discussing risk. I wonder if this explains how some care coordinators then appear to avoid discussing risk and approach it with stealth that seems to leave many service users largely unaware that anything's actually gone on. In our COCAP study, we have an example here from a senior manager in one of the senior CNHTs that we were collecting data in, who gives a general impression that sums up what many participants said to us, which is that they don't talk about risk for fear of upsetting people. When we looked at care plans in that same study, we only found 1/3 of care plans included the person's views in the risk assessment. And of those 1/3, only another 1/3 included the person's names, or the person's views in the management plan. I'm afraid we have recent evidence that was soon to be published from our inpatient study, which paints an even bleaker picture in relation to involvement in risk assessment plans. So in our studies, people using services are largely unaware of risk assessments being conducted. In some cases, they assume that the staff took the safety into account, but for the most part, were not involved in whatever happened. And this finding has been noted in other studies by Langan, by Jeremy Dixon, in other settings. And I think it is now, we can take that as a fairly stable finding over a number of studies. We have to too, I think, remind ourselves of the limits of risk assessments. Where there is use of scales, they are heavily weighted towards historical factors. They're largely concerned with risks of services or individuals will be held accountable for. They often come with no training or fail to account for drift once training has occurred. And evidence, Jeffrey Swanson says, for the use of evidence for assessment scales is actually very weak, and so weak that it wouldn't be accepted in other branches of medicine. More recent evidence shows that actually, so a lot of these risk assessment scales are no better at predicting than individual clinician or patient opinion. And the most recent recommendation has been that they should not be used for individual assessments. A consistent finding that's been highlighted by Bacordi originally in 1983 is that 96% of high-risk predictions of suicide were false positives. That's stunning. That's a stunning number. and more than half of suicides occurred in groups of people who were rated as low risk. Indeed, risk assessments are now considered to be so reliable that some commentators say they should not be used for judgments about whether people need psychiatric care, and that instead we ought to be providing a broader, more adequate standard of care for everybody who receives services. It seems to me too that assessments, that attempts to do risk assessment at street level in mental health services suggest much of what is going on is little more than a fiction. They're fables for dealing with the terrible uncertainty that both the nurse and the person is experiencing. And this notion of accepted fiction recognises that risk status is ambiguous, the outcomes are uncertain, and the consequences are significant. This idea of accepted fictions therefore centres on this ambiguity of risk assessment practices that are either transparently ineffective or for which contested knowledge about them is known but largely ignored. In all senses then, in this sense, all parties in the interaction may be aware that a proposed approach in assessment is known to be largely for administrative purposes and has little or no scientific validity. So what's happening in risk assessment practice? Well, we know that information, as I said, is not shared with the person or the family when the assessments are done. The person isn't involved and the knowledge is not made use of in relation to those assessments. It's clear that assessments are being conducted. It's not clear that assessments are being conducted in particularly evidence-based ways. And largely this is because there's very little transparency or scrutiny of those assessments, so that there is little evidence for their reliability or validity. And the consequences of risk assessment require us, I think, to act in ways that are fair and just for individuals. And I think one way to think about this is to look at what some of the implications might be arising from risk assessment practice. At best, they might keep somebody safe for long enough for them to get better, and this is largely to be welcomed, of course, though we have to remember the high rate of false positives and recognise that how safety is achieved is also important. But at worst, it denies people liberty on the basis of providing a range of treatments of contested and doubtful efficacy, based on assessments of questionable validity, and which may actually cause them harm. Loss of liberty or social restrictions constrain the social fabric for people. It disconnects them from the family, from their friends, from the community, from employment, and even a place to call home. It's likely too to have a more fundamental effect on how people see themselves and are seen by others. It has been suggested too, for instance, that a focus on predicting and managing risk may paradoxically lead to less assessment and management of actual risks, because workers become fearful that if they identify something such as suicide, they may be responsible for eliminating it and don't have the skills to do so. What worries me is that people using services are subjected to potential negative effects of risk for little apparent benefit and without any means to participate or contribute their knowledge to the solutions. This lack of reciprocity is problematic and unacceptable, but even more fundamental injustices seem to be at play. These include what Miranda Fricker refers to as epistemic injustice. And this she defines as a wrong done to a person in their capacity as a knower. And she highlights two types of epistemic injustice: testimonial and hermeneutical injustices. The testimonial injustice occurs when prejudice causes a hearer to give a deflated level of credibility to what someone else says, or it leads to people excluding or failing to seek the views of individuals based upon some prejudicial idea. And hermeneutical injustice occurs when there's a gap in the collective interpretive resources which places somebody at an unfair disadvantage in making sense of their social experiences. In risk assessments, in conducting risk assessments, I think without the knowledge and involvement of the person, we're in danger of creating testimonial injustice, viewing what people say as somehow less valuable than our own knowledge as professionals. And by failing to share this knowledge, we create wider hermeneutical injustice within the group of people using services. Risk assessment, I think, and its management in contemporary mental health services places all the cards with one group of people and successfully manages to keep another group of people in the dark. This isn't fair. It isn't just, and it isn't, I think, how to build modern, forward-looking and collaborative mental health care systems. Mental health nursing, I think, as a profession has a big contribution to make here, and I think we can do an awful lot better. And some of the suggestions that I have, I'll just quickly go through. I think we do need to find ways of talking about difficult things. People in mental health care, we know, as we've pointed out, and lots of other people have found too, value relationships. And it seems an odd thing to have to say that, because we might all intuitively have a grasp of it. I think we take for granted the idea of therapeutic relationships. We take it as a given, and we don't maybe pay as much attention to it and to working at it as we could do. Workers value relationships, service users value relationships. And forming meaningful relationships, we have an opportunity to be honest with each other, to have trust in what people say, and to develop a sense of shared understanding of what might be at stake and how best to deal with those issues. In our COCAP studies of community mental health teams and inpatient services, and in our Old Wales study, Plan for Recovery study, we found people saying all of this to us fairly regularly. But we also found service users telling us that they barely knew who their care worker was, that they could not confide in that person, and that they had no sense of sharing in decisions about their care. That seems to be problematic. Even in the most pressured of circumstances, making time for establishing and maintaining relationships should remain a priority. In some cases, it doesn't seem to be happening. We need to focus on dealing with distress with empathy and compassion, and recognise that meaningful engagement is the core work of our profession and may have inherent protective qualities. We can communicate that we're concerned about safety and interested in working with people to manage this. We should begin to do this by simply perhaps having conversations about risk and safety with people using mental health services. And there are a number of potential fruitful avenues that we could explore in relation to this. For instance, some of the work coming from out of Finland on open dialogue approaches looks like it might be really very interesting. Here's an example. This quote here is from a service user in our COCAP study. And what they're indicating, you can see quite clearly, is a sense of reassurance of having had that conversation and the potential of engaging in solutions for dealing with issues of safety. In building relationships, we do need to pay closer attention to the language we use. Borman and Roberts have noted that risk assessment language is negative and inclined towards distressing outcomes. Participants in our recent inpatient study noted that a barrier to participating in care planning was that the content was upsetting, that it focused on negative experiences, that it emphasised limited resources, or was simply dark. So how we talk about risk is important and has important implications for how people see themselves and are seen by others. If we orient towards people as risky and take steps to limit or restrict opportunities, then over time, whether it's openly stated or not, it is likely that these same individuals will come to see themselves as people who are unsafe, who must be watched, and who must endure limits on their personal liberty. The contradiction in here, of course, and you'll spot it immediately, is that these ways of seeing oneself emphasise dependence rather than independence. And that flies in the face of any claims that we might be making about providing recovery-focused services. We need to move from a focus, I think, on control to one in which we work with people to address their safety issues. Our position, I think, has been to place professional knowledge above lay knowledge and somehow carrying greater weight and being immune from the contamination of non-empirical or cultural influences. I think this is in part prompted by anxieties derived from organisational pressures about reputational risk. An alternative, though, is to maximise and mobilise available resources around the person towards learning more about risk and its management. And in doing so, we can help people and their families to build their confidence and knowledge about what can be done to address their concerns. A key element of all of these resources is knowledge from the person and their family. And there is good evidence to suggest that service users' evaluations of their own risk are prospectively significant. There is expert knowledge, despite what Michael Coffey might have told you. There is also lay experiential knowledge. And adopting a multiple perspectives approach in which they are allowed to sit side by side, we might be able to engage people in risk assessments, not simply as a provider of responses to set questions which will then be judged later by experts, but as valued knowers with contributions to make to understanding and addressing concerns over safety. Risk assessments need to be obvious and not hidden. They need to be open, and they need to be shared. and more importantly, they need to include the knowledge brought by the person themselves. Mental health nurses have the skills to facilitate all of this involvement, but in not doing so, I think we neglect opportunities to demonstrate those skills and to position ourselves as relational experts. So, if we want better risk assessment management process, then we need to do more than simply pay lip service to involvement. But we also need to build an evidence base, and then we need a new evidence base that recognises some of the limitations that we've already had. I see I've been locked out of my last slide, and perhaps that's telling me that I'm actually over time. So I will finish on that point. And it is, I think, a strong point. If we could have that last slide back up, that'd be really helpful. I think to borrow and to slightly subvert the well-known phrase that we will all will be very familiar to people in this room. I think every discussion about risk should be about the person should be with the person. Thank you. I didn't get my last slide.
Thank you, Michael. We're going to move straight on to Paul French's presentation, and then there'll be an opportunity afterwards to take questions from both of our inaugural mental health nurse academic lecturers. Thank you, Paul.
Well, thanks very much. Thanks to Ben, thanks to Steve, thanks to the organising committee, especially thanks to John and Alicia who kind of put me up for this. So huge thanks for all of those not worthy cognitions that you kind of instilled and the sleepless nights worried about the talk. So huge thanks to John and Alicia. They asked me to kind of put together some kind of an overview of some of the work I've been involved with over the years, rather than kind of focusing on a single study. So I guess I'm going to try and tell a story through some of the research trials that we've been involved in about how we've been trying to kind of move forward, about kind of promoting the real sense of potential for recovery associated with psychosis, and I'll draw on a number of studies in order to do that. I've been a mental health nurse for a number of years now, kind of over 30 years, and I guess I've constantly worked with people with diagnosis of psychosis. That's been my kind of real passion over that period of time. And I guess in terms of the research I want to present, in some ways it's not what's typically classified as nursing research. I guess what I do is I do research, and I'm a nurse. I guess that's the focus of the work that I've done. I've done research which has been focused around psychosis and moving forward that notion of recovery in psychosis. Is it this one? Before I do that, I just want to kind of highlight, I mean, I kind of put forward my abstracts and said, oh, I want to talk about psychosis, and that's what I was going to do. And then kind of a little way into the process, we unfortunately had the tragic incident in Manchester, and the Manchester Arena incident where sadly lots of people lost their lives and many more people were traumatised. And I was involved in developing the adult clinical pathway in regard to this incident. And we've had a huge amount of learning already in an incredibly short space of time, and I wondered, should I do a talk on this instead? And I kind of was a bit of a pain in the arse, and I contacted the organising committee, can I change my talk? Can I change my talk? I think it was great, but I thought I'll stick with my main focus. But I just want to put a couple of slides up to kind of highlight the work that's been going on in Manchester, which I think is incredibly important. Following the work that we did, where we developed clinical pathways for people kind of experiencing trauma following kind of these kinds of incidents. There were the incidents in London, there was the London Bridge, and there was Borough Market, and then there was the awful and just devastating Grenfell kind of events, which was just on a whole different scale altogether. But the work that we did, we worked incredibly closely with our children and adolescent colleagues. And I've worked in adult mental health, as I say, for over 30 years, and it's very rare that you kind of cross over that boundary and work with your CYP colleagues. But for this piece of work, we worked intimately together. We absolutely developed a partnership where we developed guidelines that were absolutely seamless in terms of what they kind of look like, in terms of the language that we utilised, in terms of the interventions that we were kind of advocating for. So this was a real opportunity where Manchester absolutely came together as a whole system of care, not just across kind of adult and children and young people, but across a whole system of delivery. A real system where all of the mental health trusts worked together, the social services came together, our voluntary care sector came together, and we all worked to kind of overcome the kind of difficulties. And we did a huge amount of work where actually what we saw was a huge amount of healing in Manchester. There was a massive amount of healing took place. And that's been a real positive kind of issue. But there's a real kind of sense of a lot of work to be done. There's an incident that happened in Tunisia. There was a shooting on the beach in Tunisia a few years ago, that some of you may recall. And following the Tunisia incident, there was a kind of screen and treatment kind of program that was established. And this was the numbers that they had in terms of the Tunisia screen and treat initiative. And if you extrapolate those numbers out to the cohorts that we have involved in the Manchester incident, you see huge numbers of people in terms of exposure to trauma who are likely to have some kind of complex kind of difficulties going forward. On the back of that, we set up a trauma resilience hub in Manchester. We absolutely are following people up. We have lots of real positive aspects in that this was a ticketed event. We actually managed to get hold of the kind of details of people who attended that ticketed event. And we're in the process of contacting people at 3, 6 and 12 months in order to offer out normalising information to suggest that it's still likely that people will still be having difficulties. But if they're kind of causing you distress and problems, then actually what we want to do is screen you for those difficulties and quickly stream you into care. And that's a really important aspect. So there's been a huge amount of work where the system has worked incredibly well in Manchester. Anyway, so moving on. These are the studies I want to draw on in terms of the rest of the talk today. And I'm not going to talk about every single one of them, but they've all in some way shaped the kind of the messages that I want to kind of deliver today. But I guess what you really see here is not just a huge amount of work, which it is, and a pretty big substantial sum of money. What you see is the ability of researchers to kind of, really be able to impact on their design logos over time. There's some really aggressive design logos which happen over time. You see in the early stages, we weren't overly creative. We had Eddie, and then that real creative stage went to Eddie 2. That was a real kind of momentous thing. So I want to draw on lots of those. So, I know that Jay, I don't know if Jay's still around today, but Jay indicated yesterday that in terms of psychosis, when we moved on, that kind of psychosis is somehow assumed with a more lighter diagnosis. I'm not so sure that is the case, but I think we've come a huge way. But certainly for a long time, the diagnosis of psychosis was absolutely assumed to be a psychotic, to be a catastrophic event. Constantly hear stories. A great colleague of mine, Eleanor Longdon, has done a TED Talk, and if you do anything after this, log on to kind of TED Talks and look for Eleanor Longdon. And in terms of trauma, Eleanor really sets the story very clear in that what Eleanor finishes with her TED Talk is that in terms of trauma and psychosis, what we shouldn't be asking people is that what's wrong with you? What we should be asking people about is what's happened to you. And I think that's a really important message. But Eleanor also tells a story about being told by clinicians that she would have been better off if she'd been diagnosed with cancer. And this is not the only person. I've heard many people recount similar kind of tales. And we've known for a long time, that travesty that people die 20 years younger than their peer groups. The travesty is also that we've known it for a long time and done very little about it. So what I want to do is focus on trying to think about what can we do to impact on some of those things. And it's those kind of issues I want to focus on. So the interventions I want to kind of talk about are some of what we've been involved in terms of looking at early interventions, in terms of early symptom development, focusing on functional rather than just symptomatic recovery, interventions to tackle physical health inequalities, and strategies around stigma around psychosis. So interventions in the kind of early course. This was a recent campaign that was out some time ago. It just beautifully illustrates kind of the fact that, you know, when your car breaks down, that nice man from the RA, the AA or the RAC comes along with a short space of time. And within kind of, you know, 60 minutes you get help. But the notion that when you have psychosis, what we've known for a long time is that actually around about, you know, 12 months is the average. Up to 18 months is what we kind of, you know, saw, but round about 12 months was the average length of time that it took before people got access to care. We did some work and we produced some guidance. We looked at actually what predicted kind of, you know, what we should be looking out for in primary care to identify people with a kind of an emerging psychosis. And I worked with a fantastic colleague, a gentleman called David Shires. David's a wonderful colleague and friend. And with David, we produced some kind of GP guidance based on the work that we did to identify people who were at risk of developing psychosis. Interesting work that we got here. We published this, and it was published through the RCGP. The RC Psych kind of badged it as well, and the BPS, but the RCN didn't endorse it at the time, so we felt a bit of a shame really, missed opportunity. But that helped to spur people kind of to be kind of identified to services in terms of emerging psychosis. And this is one of the first early clinical trials that I was involved with back in 2004. And this was where we identified people who were at an elevated risk of developing psychosis. So you hadn't yet reached the threshold for psychosis. You had that at-risk mental state kind of presentation. And we kind of offered psychological therapies to see if what we could do is prevent the onset of that progression to a full expression of psychosis. And in this trial, we thought, well, you know, there are various ways of cutting this. You know, is psychosis just a change in terms of PANSS scores? Is it about the way people are prescribed medication? Or is it about diagnosis associated with DSM? But what we did was, regardless of the way that we kind of thought about psychosis, our intervention dramatically reduced transition to psychosis in this high-risk cohort, whichever way we thought about it. So really thinking about kind of preventing that trajectory, and preventing that movement into things, a preventative approach in terms of psychosis was a real kind of step forward, especially when you think about recovery. That led us to developing a treatment manual. The title really trips off the tongue. It's a really easy kind of title to remember. And this was the basis of some of the work in terms of my PhD. And interestingly, I'm not put that up just to kind of, you know, demonstrate how writing books, but actually this treatment manual that we wrote was then the subject of a number of trials which took place not just in the UK, but in Canada and in Holland. So that's important for thinking about this slide, which is a meta-analysis that we did. And it was with some of the real grown-ups in terms of early intervention in psychosis. You know, people like Alison Young, Pat McGrory, Mark Gard. And the real joy, we also had Tim Kuipers, who's a real expert in terms of doing work around kind of meta-analysis. And we looked at, you know, what preventative strategies you could employ in terms of preventing psychosis. And we looked at a range of different interventions, from antipsychotics to omega-3s and CBT. And CBT was the one that came out pretty robust. There's another meta-analysis done by Button and Taylor. And in terms of that, they didn't look at the other things, they looked purely at CBT, and their conclusion was very strong in that CBT-informed treatment is associated with risk of transition at 6, 12, 18 to 24 months, which is a really strong message. That led, in terms of the NICE 2014 sort of guidance around psychosis and schizophrenia, to actually include for the first time about prevention of psychosis. So this was a real opportunity that now we're starting to get into NICE guidelines talking about prevention. And pretty much what they're saying is offer individual cognitive therapy. They do say with or without family intervention. There's actually not a great deal of evidence in terms of family intervention for people at risk of psychosis, and we're currently doing a trial in order to try and impact on that kind of data. But it also led to the access and waiting time standard. The access and waiting time standard was an incredibly ambitious way of thinking about let's redress the difficulties that people with psychosis face. We know we've had access and waiting time standards for people with cancer, in terms of surgery, in terms of A&E attendance, but there was nothing in terms of mental health. This was the first access and waiting time standard introduced for mental health, and Norman Mann was central to this. It was a Cabinet Office announcement, and we had to run at pace in order to turn that Cabinet Office announcement into reality. So more than 50% of people experiencing the first episode of psychosis were treated with a nice improved package of care. They also introduced the at-risk mental state of psychosis. I was part of the expert reference group that developed this standard. And at first we thought, wow, it would be great to do, but it would be a bit bloody tricky. And they did it anyway, which was a real boon. This gives a sense of how we're doing in relation to that. So this is data from the final quarter of 16-17 and shows where we're at as a system of care. So in terms of England, what you see is that 76% of people have been seen within a 2-week time frame. Not only that, but you see that kind of 90-odd% of people have been seen within a 6-week time frame, 98% within 12 weeks. That's across England. That's incredible. Locally, the mental health organisation that I work in, we're seeing the fact that actually 90% of people have been seen within 2 weeks. 99 within a 6-week period, 100% of people within 12 weeks. This is an incredible turnaround that actually any healthcare system across the kind of globe would be absolutely envious of. I can't believe that I don't hear more about this in the press. This has been a revolution in the way that we kind of develop life chances for young people with emergent psychosis in terms of the work that we've done systematically across the care of people with psychosis. So clearly it's not just about getting into services, it's not just about symptoms, it's about kind of focusing on other aspects of care. Clearly what people often ask us when we do kind of interventions, what they ask for is actually what I'd really like for is I'd like to do something with my time. I'd like a girlfriend, I'd like a job, I'd like to go to college. I want to just be doing something for myself. And functional recovery is a real thing that we need to tackle. This was from a paper we did a little while ago that looked at just what people were doing with their time use, what people were doing with their time. And it's really interesting that the time use, there's lots of kind of general population data. And what you see in terms of general population, in terms of kind of averages, that, about 60 hours per week people are busy. If you've got an at-risk mental state, that drops by a half. If you've got a first episode of psychosis, that drops by a half again. And people who've got kind of delayed recovery goes even further. These are people who sat at home, sadly doing nothing. They're doing very little with their time. They're ruminating on their difficulties. They're isolated. So doing something where we can impact on what people do is a real kind of must. We developed a kind of a trial which we put through to the HTA, and this was prevention of long-term social disability in people with emerging severe mental illness. We actually saw lots of people with kind of at-risk mental states in terms of this. So the PICO associated with that was that there were participants who were people who emerged with complex mental health problems. Our intervention was a social recovery-orientated intervention compared against treatment as usual. And interestingly, our primary outcome was time use. So this is an HTA trial that normally kind of pretty kind of clear that they want kind of symptom-based stuff. We managed to get a functional kind of thing into this, which was really impressive. So this was a prodigy trial. We had to do an internal pilot. Internal pilots are a really interesting thing. They're great. They make lots of sense in terms of the participants that come through. It gives you time to kind of plan your research. It gives you kind of a way of testing whether or not your protocols work. And it also means that the participants that have been through, if that first bit of the study works, they just flow through into the next main trial. So it's a good, sensible way of doing things. And that's what we did. And this was some of our data from our internal pilots. What we see is in terms of very low functioning. So between 0 to 15 hours, that's where the majority of people are coming into this trial. And what we also see in terms of their baseline scores is that there are huge amounts of social anxiety, huge amounts of depression, and huge amounts of hopelessness. And this is a cohort that we're currently working on. We don't yet have the results, but we've recruited to time and target on this trial. We've got high rates of retention, and some of the kind of stories that we've got, we published in, I think it's British Journal of Psychiatry, who actually published a qualitative piece about young people coming into research and we're really finding benefits of this. But I don't have the kind of the results from this as yet. It's going to be a year or two before we have the final results. But people coming through are really valuing this kind of work. I guess I want to really highlight this notion of recovery and impacting on people's physical health with psychosis. As I indicated, we know that people die 20 years earlier than their peers. It's absolute travesty. One of the things that we know drives some of that, it's not the only thing, but one of the things that we know drives some of that is the fact that, within the first kind of couple of years of people starting on antipsychotic medication, that their weight gain, so this is 12 kilograms within 2 years. So you equate that to just under kind of, 2 stone. Imagine putting on 2 stone. You guys know what it's like, after Christmas, we've had a bit more to eat than you normally do. You feel pretty sluggish, you feel pretty awful. It doesn't even improve your self-esteem. So imagine putting on 2 stone. Not only that, but that's what drives lots of the kind of conditions around metabolic disorders, which is so important. But it indicates that we've got a real opportunity to do something here. Did some work again with the eminent Dr. Shires. Dr. Shires loves a good leaflet, and we produced one. Well, I said we produced one. We actually conducted focus groups with people who use our services. So this was pretty much developed by kind of young people who use our services who are coming into early intervention in psychosis. And what we wanted to do was, I guess the emphasis has for a long time been on services to say, let's get these things right from the start in terms of your physical health. Actually, what we wanted to do was redress some of that. And actually what we wanted to do was give our people who use our services a leaflet that they could present to services and say, actually, I want you to get my physical health right from the start. This is what I'd like to deliver. The other thing that I've been involved with is a large trial. This was a trial called Stepwise. This is a 10-site trial. I'm a Manchester PI in terms of that. It's been led by a guy called Richard Holt, who's a professor of diabetology. And what we've been trying to do is see whether or not we can utilise lifestyle interventions, which are developed from working diabetes, to see if we can prevent weight change. Sadly, again, I can't present the data. The data is going to be unveiled in Berlin next month, so you get the opportunity to go to Berlin and talk about it, which will be really nice. But what's important here is this is another trial that recruited just incredibly well to target. This was a group-based intervention. People, tend to assume all people with psychosis, they don't want to get involved in groups. It was a group-based intervention around weight change. We absolutely we could have recruited more. People were desperate. The people who use our services are desperate for interventions in order to kind of change that kind of awful trajectory in terms of their physical health. This is really important. What we see is that in terms of the people that we did recruit, in terms of their BMI, BMI was around about 30, 35. This is a pretty kind of, obese that would be classified according to that BMI chart. This is an obese group of people who are desperate to do something about that. And actually, in terms of what we do, we need to think broader than just lifestyle interventions. There are a whole range of different interventions that we need to consider, many of which we consider in terms of the general population, but do not consider for people with a diagnosis of psychosis. What I want to do next is move on to that notion of stigma. And I guess what we've seen is we've seen lots of campaigns to raise awareness of mental health stigma. There's been the MQ, This Is Time to Change. I think my favourite is the Only Us campaign. People heard about the Only Us campaign? Anyone? No? Look out for the Only Us campaign. I'm sure Andre will put something on Twitter to highlight the Only Us campaign. Lots of the other kind of stigma campaigns tend to continue to promote that notion of 1 in 4. They put forward that notion of 1 in 4. That 1 in 4 of us is somehow different to the other. But maybe, somehow, 1 in 4 of us is somehow less resilient, less capable, perhaps more vulnerable, perhaps different. And it kind of instills a notion of them in us. The Only Us campaign flies in the face of that. It says, well, there is no them in us. It's only us. We're all vulnerable. And the Only Us campaign is a really beautiful way of thinking about the kind of notion of stigma in terms of mental health. But there's also the Heads Together campaign. I'm not a particular royalist, I have to be honest, but we had Harry come down and visit us in terms of the Resilience Hub a couple of weeks ago, and it was incredible to meet him. And you know, when we kind of get to meet someone like that, who's really had an impact in terms of kind of challenging stigma, it's a real opportunity. But associated with all of those things, there's been so little. If you think about all of those campaigns, you think about Time to Change, think about the Heads Up campaign, think about all the others, how often do they talk about psychosis? They talk about anxiety, they talk about depression, they talk about eating disorders, they talk about PTSD, very little talk about psychosis. I did some stuff a few years ago where I did a podcast. It was a pretty awful podcast. It was pretty much, me doing a talk. It was a bit Radio 4, it was a bit crap in some ways. But actually what we found was you can actually really challenge kind of stigma beliefs by just doing the podcast. So I got really interested in how we could utilise things like podcasts or the arts in a way to kind of, see if we could do some work about challenging stigma associated with psychosis. It was great. I then got involved with an organisation called Ziggy's Wish, and it was a real kind of opportunity to kind of think about how we could utilise arts in order to kind of challenge the notion of stigma and psychosis. So Ziggy's Wish is based upon the story of a young man, and this young man had a diagnosis of schizophrenia, tragically took his own life. His sister Ravi and collected all of his artworks and his poetry, and she turned his poetry into this beautiful graphic novel, and we got to meet at some conference or other, and I was astounded about the work that she'd done. She also turned some of his kind of experiences, which was basically a tragic love story about his development of psychosis, into a stage musical. And what we decided was we'd kind of try and evaluate that piece of artwork, that beautiful artwork, graphic novel and a stage play. And the way that we did it was that Ravi created this incredible app, which people were able to download before they came to the project, and they were able to kind of fill in all of the questionnaires through the app. And so as a researcher, it was great. I just sent all the data straight to our Excel file, direct from this app, before they actually saw the production, after they saw the production, after they had access to the graphic novel, and 3 months later. Now the data is pretty much all in as of last week, so I don't have the actual data on whether or not it had the impact. But just the process of using the arts as a way of engaging people to tell stories about stigma is a really important opportunity that we just cannot miss. In terms of some of the stuff, in terms of some of the demographics, the people that we got was kind of over 300 people who kind of completed follow-up and stuff like that, so we got that. But one of the things I think is vital, we actually struggled to get people through the door in terms of this production. The production had been run before, and it was run at one of the big kind of theatres in Manchester. It was sold out on a couple of occasions. We sold this as a project where we're challenging the stigma of psychosis. Interesting, as soon as we kind of talked about this is a project about stigma and psychosis, and word didn't come. The theatre, the production was astounding. It was beautiful. It was an incredible piece of theatre, but we really had problems getting people through the door. So I think there is still a huge amount of stigma associated with psychosis. So I guess in conclusion, there is hope and optimism within our services. It's absolutely embedded, but I think that we've still got a huge amount to go. Promoting recovery absolutely requires multifactorial approaches, not just one single approach, it's got to be multifactorial. Nursing is absolutely, ideally and uniquely situated to contribute to that agenda. But what I constantly feel frustrated with is that in terms of the people who come through research in terms of mental health and psychosis, it's incredibly limited. We need to continue to kind of give access to our clients, access to clinical research that we can kind of make a real change to their lives. Cancer UK had more than 25,000 participants during clinical trials last year. Only 4% of the research budget went into mental health last year. 4%. That's diabolical. We need to continue to drive clinical research. I think that's me done. I think I'm hopefully round about time. Thank you.
Thanks very much, Paul. Well, we've got plenty of time now for questions from the audience. We have 2 roving mics there at the back. We'll need to use the mics just to make sure people can hear all the questions. Really stimulating talks, and I'm sure you're chomping at the bit now to ask our presenters further. Who's going to be first up?
Thank you very much. Alan Simpson from City University, London. I really enjoyed both those talks. I thought 2 people at the top of their game, measured, thoughtful, informative, got a lot from it. So much I couldn't keep up with the tweeting, so thanks very much. My question for both really is, you've both touched in different ways on the issues of stigma and discrimination and marginalisation. And I'd just be interested in a bit more of your thoughts on what you think as mental health nurses we can best do about challenging them.
Well, thanks for that easy question. A few years ago, I had the pleasure to meet Peter Beresford. Many of you probably know Peter. He's at Brunel. I think he's retired now.
I'll have to interject there and say he's at the University of Essex. He's just moved.
Oh, is he? Okay. Didn't know it was a bit more and Peter came to Swansea to do some talks for us. And yeah, we talked about stigma, and we talked about stigma campaigns, and he was furious. I don't know if you've ever met Peter, but he seems to be a very passionate man, and he had a particular problem with New Labour, I seem to remember at the time. But his issue about stigma was that a lot of the campaigns didn't engage with people who use mental health services. And he said, how are we ever supposed to challenge that when we've got people here who know what it's like to experience this and haven't had the opportunity to contribute their knowledge to... So see, it's almost like I'm harking back to what I was talking about earlier, but this is a kind of a theme running through the way things get done. Is that we don't make use of some expert knowledge that's already out there, and we need. I think mental health nursing ought to be engaging with people to think about ways in which we can address issues about stigma and maybe more directly discrimination in people's experiences.
Yeah, thanks for the question. I think the terminology is right, and I kind of apologise that I used the term stigma. It is absolutely about discrimination. We shouldn't hide that fact. We don't talk about the stigma of being male or female. We don't talk about the stigma of being old age. We talk about discriminatory kind of practices. And I think we absolutely need to move towards that language of recognising that actually it is discrimination that is applied to people. We can't do enough. We employ people through our psychosis research unit who have had very clear experiences of psychosis. I've mentioned Eleanor once, I can't mention Eleanor enough times, who is an absolute inspiration in the way that she has transcended a diagnosis and talks about her difficulties and the way that, her TED Talks have, I think it's 3 million hits. For a TED Talk, that's phenomenal. Really is kind of a huge kind of platform for her to be able to tell a story about kind of transcending the difficulties associated with psychosis. But I think we continually need to kind of utilise people who use our services as much as possible to demonstrate those recovery stories and engage and kind of utilise that survivor network to really promote the fact that absolutely people can do so much. And we need to move away from that kind of sense of doom and gloom that's associated with mental health conditions.
Thank you both. Any further questions at the back there?
My name's Maurice Moikis from the University of Birmingham, and I'm also a governor in the local mental health trust. And one of my concerns around the management of risk that seems to be happening increasingly in the trusts that I'm involved in is a search policy, and that's service users being searched on entrance to the units where they are patients being cared for. And the concern around that is the use, my concern is around the use of nurses being the people who are searching, and they can be searching people repeatedly, sometimes if they're of the same gender as the service users, all day. And I just wondered whether, I'd open that out to you on the panel, what your knowledge is around that, but also in the room, and whether that's something that's happening in other areas. So searching for, under the guise of searching for weapons, but also on things that are being called contraband, as in drugs, cigarettes, crisps in some cases. But I just wondered what your thoughts are around that, and the impact on the therapeutic relationship.
I'm a bit flabbergasted, to be honest. I've heard you say that. I can recall a few years ago going into a PQ and where they'd installed some equipment like going into an airport, and they had security guards who looked quite poorly people. And I thought, what sort of a welcome is that for somebody who's in mental distress? When I showed a picture earlier on of that Victorian institution where I trained in Dublin, I was thinking about it this morning. I was thinking about my first day when I went there to start my training back in October 1984, and it frightened the life out of me. And because it seemed so foreboding and ominous. And if we are now getting to a situation where we're starting to treat people who are appearing in mental distress as if they're going into a prison environment, I think that's problematic. What it does for the therapeutic relationship, well, I think we should have great hope about mental health nurses, because I think mental health nurses can do this sort of work. I know we're put under pressure, I know organisations want us to be risk aware, etc. But I think mental health nurses are fantastic people, and I know many of you in this room, fantastic interpersonal skills who can handle even the ridiculousness that organisations might be placing upon us when we actually deal face-to-face with individuals. And I just think we have to remember that humanity in those situations.
I'd like to respond because my name's Cheryl Kipping. I'm a consultant nurse for dual diagnosis at South London and Maudsley Trust, and I feel really passionately that we should be searching people. I think we have a responsibility to keep our wards safe for people that are often very vulnerable, and obviously my focus is on drugs and alcohol, and we know that if people bring drugs and alcohol and share them around, then that has very significant consequences. We also know anecdotally that for many people, their first experience of using illicit substances is on our psychiatric inpatient wards, and that is not acceptable. For me, it's not acceptable. So what I think is really, really important is that when we're searching people, and we use drug dogs on our premises, and I know that some other trusts do as well, that the way in which the search is conducted are in a way that's done that respects people's privacy and dignity, that we've spoken, picking up the points that you made about talking to people about these things, that we need to make people really aware, both service users and families and carers, about what we're doing, why we're doing it, explaining why we're doing it. And when we've done things, we did, there were some people that presented at this conference actually a few years ago who've done a small project looking at service user, carer and staff use of drug dogs, and actually all groups were largely in favour, and it was about making them feel safe.
just one response. I have no objection to the process. What I object to, and I've been a nurse for 40 years this year, I know that's hard to believe, but...
Amazing.
Thank you. I just do not see it. If I was going into a job and somebody said to me, well, how do you want to spend your day? Train for 3 years as a mental health nurse and then spend your whole day searching people. I wouldn't want to do it. And I understand the process, but there is an issue, and I think it needs to be looked at.
Okay, thanks. We'll move on now to a question here. Well, I think this lady first.
Hi, thank you. I'm sorry I missed your presentation because I was late. I want to respond to what you were saying, and I forgot your name because I was late. And also for being on time. But I sort of feel obliged to ask you if you've ever heard about the open dialogue approach. Because in terms of early intervention in psychosis, it has the best research outcomes in the Western world, and it's the most researched approach. And it was developed in Western Lapland in Finland, but has now been taken up in New York and many places in Europe. And I was struck when you said that in one of your bits of evidence that family intervention didn't seem to be significant, whereas with the open dialogue approach, I'm sorry if I misunderstood that, with the open dialogue approach, the family, and it's a network-based approach, and the family and the person themselves are at the very centre of all the work. So I just felt that I needed to kind of ask that. That's not to take away from the great work that you're reporting on.
The open dialogue approach is simply one intervention, as you indicated, it emerged from Finland. I'm not sure the evidence is quite as strong as you kind of indicate. I think it's an emerging evidence base, and it is by nowhere near as clear as the evidence base for family intervention and psychosis. Family intervention for psychosis is probably one of the most robust interventions that we have to reduce relapse rates associated with psychosis. It doesn't necessarily reduce symptomatology. What it does do is it reduces relapse rates, and it's a very, very powerful intervention for doing that. So the reason why you have individual psychological therapy, which has an evidence base around reducing symptomatology, and you combine that with family intervention, is that if you put the two together, then actually you reduce kind of relapse and you reduce symptomatology. So there's a very robust evidence base behind both of those. The open dialogue approach is very interesting, and we absolutely need to see how it unfolds, but I don't think there is that strength of evidence behind its approach as yet.
Okay. We have 3 questions lined up here, so after these 3, are there going to be any further? We have 5 more minutes for questions, so just let me see who's got a burning issue that they want to get addressed before the break. Okay, we'll do these 3 in order, 1, 2, 3, and then see where we are.
I'm John Crowley, from the University of Greenwich. And I guess, like my colleague before me, I'm also a trust governor. I've been involved in a number of inquiries over the past few years. And I guess my observations are there's something fundamental about how nurses view risk that are really led by procedures or protocols that is different to other disciplines. Somehow there's a creativity, certainly in medicine, and I would say psychology or OT. And are we doing something fundamentally wrong in undergraduate training? Or is it that we're simply, I guess, bound to sort of organizational sort of pressures? And I wonder if you had any thoughts on that.
Thanks, John. Well, in a way it's a big question with lots of different types of answers. I think, I alluded to it in my talk. When I came into nursing, nobody ever talked about risk at all. But we did do things to keep people safe. It wasn't that we weren't aware of it, or we weren't thinking about it, but we weren't pressured by the organisation beyond making sure that we tried to keep people safe. I'm not sure that we always did that in the best ways, and I think knowledge is evolving. But all of us in this room have probably been in the profession for many years, and we've seen what has happened over those years, which is that there's been a reduction in types of numbers of people who are being trained. There's fewer qualified staff on wards. There's massive pressures around organisations. Acuity has gone up. And, you know, a combination of pressures and political pressure externally to organisations has kind of squeezed what it is to be able to do mental health nursing. And I think you can point the finger at all sorts of things. You can say, well, training isn't doing what it should be doing. But 50% of training is happening in practice. So, you know, there's an issue about what people are experiencing too. And what people are experiencing on the ground is a massive attempt, I think, to try to control what might be largely unpredictable. And there's big anxieties around that, and absolutely there are big anxieties around it. So I don't know if there's an answer to all of that. I think that we, as a profession, might want to start just recognising it and saying it and talking about it, and maybe starting to engage with people who use services to start to think about what we might do differently.
Thanks, Michael. I'm going to move on now to another question here. We've got 1 minute probably for each question.
I'm very Tomlin from Mental Health. It's really interesting to hear this discussion about intervention for psychosis, and I definitely couldn't tell a call about the flakiness of open dialogue research currently. Really exciting, but I think we need to step away from shiny new things and have that sort of view in our mind. Really interesting, but very flaky evidence currently. I wonder about your thoughts on medication, because you mentioned medication once in your talk to highlight the side effects, negative effects of antipsychotics. Do you see these psychosocial interventions that you're developing as a replacement for medication in early intervention? And how do you think that is viewed by the general kind of psychiatric profession?
Thanks for that question. That's loaded, I think. So we've done a couple of trials around that, and we've recently done a trial which we finished and is being sent for publication as we speak. And this was a head-to-head. So this was people with the first episode of psychosis and a diagnosis. Then they were randomly allocated to one of 3 conditions. So one condition was that you got access to CBT only. The other condition was that you got access to antipsychotic medication only. And the other condition was that you got both of those interventions. We thought we'd have a real nightmare recruiting to that trial, not least because what it requires is the treatment team to kind of adhere to that treatment allocation. So they send them through to the trial, you randomise to one condition, if there's some crack rule, maybe a kind of, I don't agree with it, we're going to start something else. So it was hard to do, but actually we did it, we completed it. I'm not so sure I can actually tell the results, but they will be imminent. What I can say is we did the recruitment, and we built in lots of safety mechanisms in terms of that. So we assessed very clearly at very kind of close intervals to see if there was any deterioration in terms of risk or safety or deterioration in symptomatology, and we broke the blind and streamed people into the combined therapy. We didn't have to break the blind very often. So regardless of condition that people in, we didn't see a great deal of deterioration. I guess we're not doing this trial to say, this is a replacement for antipsychotic medication. I guess my strong belief is that people should have access to choice. And I'm not so sure people have always had access to choice of treatment through a long period of time. Antipsychotic medication has been the mainstay of treatment. And antipsychotic medication for some people is absolutely invaluable, but for some people it's not. And for those people, we need to have access to choice. And I think the trials such as this one is an ability to start to develop that choice kind of sense that we need to really embed within kind of psychosis services. We've also started to do a trial recently, so that was for adults. We're trying to replicate.
Oh, I'm going to have to speed you up there to finish it.
Sorry?
I'm going to have to speed you up. Yeah, just wrap up in 10 seconds.
We're replicating that in children and young people. So hopefully those trials give us a sense of direction from that. But it's clearly about choice rather than replication.
Okay, apologies for cutting this short. I'm afraid we don't have any more time for questions if we're to keep to time with concurrent sessions. So thanks to both of our speakers for really stimulating discussion.